Okay. Well, good morning, everybody. Welcome to our cardio echo QI cardiovascular series. You can see all of our partners at the bottom. We've gone through these slides a few times now, so I'm not going to spend a lot of time on them, but this is all about what cardio is and how we were founded in 2017. And you can see our partners at the bottom of the slide. This is our agenda for today. I'm going to do an introduction, then we'll do a QI presentation, then I'll turn it over to Gautam and he'll do the clinical Pearl and case study discussion. Then we'll hear from all of you about what the hard work that you're doing, and then and Amanda will help facilitate that, and then Andy will wrap us up and we'll get you out of here by 9. So just a reminder, these are the 6 sites that are participating with us. We've got representation from 6 sites across the state. And this is your very attractive leadership team. Thank you. So you know all of us by now. We have no disclosures. If you would like to receive CME credit, email or chat Andy during the clinic. And if you don't receive an email, contact Kathy Sullivan to complete your CME evaluation. And her email is at the bottom of the slide. So today we're going to understand how to scale PDSA cycles from small tests to system level change, apply ramping strategies into your project, and learn from real world examples to sustain improvement. Remember, please do not share any PHI. All right, so we're going to get started on our clinical presentation or QI presentation on ramping up PDSAs and small tests of change. You all know who I am and what my title is, so I think we can move on. So why is this important? Well, hypertension affects a large portion of the population, making it a high impact condition for quality improvement. Even modest changes in care processes, such as timely follow-up, patient reminders can lead to measurable change, and PDSA cycles allow teams to iteratively test these small changes and scale what works. You want to start with simple, achievable interventions, which can generate quick results. Successes in the early stages boost team confidence and they build credibility and encourage broader participation. These quick wins are essential for maintaining engagement from the staff and leadership throughout the change process. And ramp PDSA cycles start small, which limits risk if something doesn't go as planned. They provide opportunities to observe, adjust, and refine interventions before scaling up. And this approach promotes a culture of learning and continuous improvement rather than a fear of failure. Next slide. So here's some examples of areas you could focus on. This presentation will be using hypertension as an example. Obviously, you're all not all doing hypertension. You can improve patient self-monitoring and follow-up. You can close the loops between visit data and home tracking, and you can increase the percentage of controlled blood pressure, which is defined as less than 140/90. Next slide. So here's an example. Increase the proportion of patients with controlled blood pressure from 55% to 75% by December of 2025 at Clinic A. So this is a good example because it's specific, measurable, achievable, relevant, and time-bound. The one criticism I would have of me developing this specific aim statement was that I did not define what controlled BP was, so I would probably add that in the next time. So it just helps keep things very, very clear. Next slide. So when you've seen the model of improvement before. So this is just a different way of looking at it. So you want to begin with your 0 stage from theory to improvement. This is where you make a prediction. What change do you think will lead to an improvement? It sets the foundation for your cycle by aligning everyone on a specific goal and measurable outcome. Then you're still in this, the blue quadrant of the PDSA cycles where you plan for the change, identify what you want to test, how you'll test it, what data you need to collect, and also like the who, what, when, and where of your plan. Then you move on to the do phase where you implement the intervention, record what happened, and begin collecting data and observations. And you're going to study your results. You're going to complete the data analysis, compare your data to predictions, and summarize really what you learned. So and what went wrong and what went really, really well. And then you're going to make a decision. You're going to adopt the change, you're going to abandon it, or you're going to run through the cycle again. or you might adapt it. There might be things that you could tweak to make it more to see better results. And this is where the ramping starts. So once you get to step 4, then you're going to move on to your next PDSA cycle. Next slide. So here's just an example of how it would start. You've got to start with hunches or theories or ideas. Then you're going to test. You're going to test early and simple, and so that this is designed to help you learn rather than succeed. Then once you learn what went well, and you make a decision to adapt, adopt, or abandon, then you're going to move on to your next PDSA cycle. You're going to test it over a variety of conditions and understand scalability and identify weaknesses. And really, these later tests are designed to predict and prevent failures. And then once you have achieved your goal, you want to try and sustain it. So you're going to not only disseminate it throughout the system, but you're going to work on sustainability so you can maintain the gains. Next slide. So here's some basic guidelines. A test should answer a specific question. Don't just do something for the sake of doing it. Know what you're trying to learn. What are we trying to improve? What results do we expect? And a test also requires a theory and a prediction. So it starts with a hypothesis. If we do X, we expect Y to happen. And then you're going to start small and collect data over time. So testing at a small scale allows you to learn quickly and adjust without major disruption. Even with these small tests, though, it's important to track meaningful data to measure. And you're going to build knowledge with multiple PDSA cycles with each change idea. One test won't give you all the answers, but each cycle will build on the last one, and ramping up slowly, expanding who, what, and where you test helps you refine the test before scaling. You also want to test under a variety of conditions, different settings, different patient populations, different staff. It really helps you understand what works and what doesn't, and assures that your change idea is adaptable and sustainable. I'm sorry, I have not had enough coffee this morning. Don't confuse a task with a test. Sending an email or holding a meeting isn't a test unless you're studying its effect. Slide. So to be considered a real test of change, the test has to be planned, including a plan for collecting data. Data from the test needs to be analyzed, and action has to be based on what was learned. Next slide. So this is an example of how you might test under a variety of conditions. So if you have a low confidence that the idea will lead to a change or an improvement, and the cost or failure is either large or small, and then you can compare it to like how your staff feels about things. So are they resistant? Are they indifferent? Are they ready? Are they enthusiastic? This gives you an idea of how you might want to scale your tests. And in the beginning, you're going to have some low confidence, and you're going to be concerned about failure because everybody wants to be successful. And that just is the nature of when you start a QI project. So you want to start very, very small. And even if the cost of failure is small, if the confidence in the idea leading to an improvement, if even the staff is ready, you still want to scale up slowly. So that's why you can see we move from these yellow colored fonts under low confidence. And we only get to the black font when the cost of failure is small, if there's low confidence and the staff feels ready. And then you can see the similar thing with the high confidence that the current idea will lead to an improvement. So really, it's like if the cost of failure is small, there's high confidence, and the staff is ready and enthusiastic. That's when you really want to implement a larger scale test. Next slide. So, and then you can test under a variety of conditions. So if your staff is evaluate your staff's experience, the patient load, the enthusiasm for the project. You can test it under different days or time of day or time during the week, the complexity of your patient load, and the physical environment of what's going on. Do you have, is everything, is everybody enthusiastic? Is that, thinking about the complexity of the patient, the layout of your physical environment. And then you want to ramp it up based on the number of staff, the number of patients, and the number of days. And these 2 slides are just guides. So this is not a rule. This is just suggestions of how you might want to think about things when you're ramping up. Next slide. So I think this is a duplicate slide. We already talked about this. So if your test fails, what do you do? You can't just quit, right? Amanda's not going to let you just quit. We're not going to let you just quit. We anticipate failure, and when we're getting started, this is how we learn. But why? Was the change not executed? Was it executed but not effective? Was your hypothesis wrong? Um, you know, if the prediction is incorrect, it's not necessarily a failure, but you're not going to see an improvement with your change, and the local improvement did not impact the outcome. So most important thing in these early stages is that you actually learn something. Here's some PDSA tips. We've talked about small, rapid tests of change. Everybody wants to think big. We all want to, fix uncontrolled hypertension or diabetes. But we have to start very small. And you're going to use repeated PDSA cycles. And as I said, the first tests are for learning. You want to keep track of everything. Test early and often. Collect just enough data to know that you've made an improvement, and then ramp up once the change idea is robust. And then the latter tests are for success. And most importantly, if you get stuck, don't get discouraged. Ask your coach. We've got a really great coach who's going to be here to support you. So just think about that. Think about asking your coach for her advice on how you might be able to move forward. Am I doing okay on time? I think I've got 5 minutes left. Okay. All right. So this is a real world example of that we're going to share in a minute. But when you think about how you want to implement a quality improvement project, you want to engage the whole team. So you've got your QI coach, you've got, your team leader, who's probably, it might be a nurse, it might be an MA, it might be a physician. It really depends on what it is you're working on. That's somebody who's going to track the data, and then somebody who's really going to reflect on things and say, point out to the team what they learned. And most importantly, you want to celebrate the small wins. And that can just be, like a small acknowledgement. Some people like pizza parties or donuts. I don't know if we want to talk about that when we're talking about cardiovascular disease, but there's always the opportunity to share something with your staff. Next slide. So this is just once again an example. For cycle 1, you might test whatever your intervention is with one patient and one team member. And the cycle 2, you might do 3 patients and 2 team members. And cycle 3, you might do the entire care team. And as I can't say it enough, but you want to use early data and lessons learned to build momentum and reduce resistance and obtain buy-in. Next slide. So this is a project that we did a few years ago. The aim of the project was to reduce complications of hypertension in Northeast Ohio. So that's a big global aim. So for one specific practice, their specific aim was to improve controlled hypertension, as defined as blood pressure of less than 140/90 from 60 to 70% within 2 years in an urban primary care practice. Next slide. Okay, so we have an urban underserved safety net clinic affiliated with a level 1 trauma center. 75% of the patients are covered by Medicaid or Medicare. The principal teaching hospital of Case Western Reserve since 1914. The clinic was the J. Glenn Smith Clinic. 90% of the patients are African American and 80% are Medicare or Medicaid. These are the team members that they chose to have on their quality improvement team. They had a primary care provider, a patient service representative, a medical team assistant, a nurse, and an ambulatory manager. Next slide. Okay, so what did they do? So their first PDSA cycle really focused on education. They started with knowledge gaps. So ensuring accurate blood pressure measurement. And then you can't improve what you can't measure correctly. So this was a really good place for them to start. And then their second PDSA cycle was they implemented huddles so that they could proactively identify patients with uncontrolled hypertension. So instead of moving from treating hypertension where they found it, they moved to actively looking for it. Then their third PDSA cycle was point of care verification. So they do a manual blood pressure check if the initial blood pressure check is greater than 140/90. So this really caught some measurement errors. And then on PDSA cycle 4, automatic 2-week follow-up with nurses. Sorry, with nursing 3 times until the blood pressure was controlled, or they had a primary care appointment. And then finally, outreach to those with elevated blood pressures if there was no follow-up scheduled. So this was more of a system level population health sort of initiative that they did with their 5th PDSA cycle. Next slide. So you can see that this shows some pretty dramatic increases in our blood repeat blood pressure. So they started looking. So they basically started this project in 2014, and they saw that their percentage of repeat blood pressures was really, really low. And then they were able to dramatically improve it in 2015. And you can see for the most part, they were able to maintain that improvement for almost 7 years. You can see there's a slight dip in 2020. That was probably due to COVID. But the thing is even with that, even with COVID causing delays in patient care, they were able to still really maintain that at about 80%. So this really shows a story of sustainability, and that they've really integrated these processes into their workflow and created a culture of quality to do this for blood pressure control. Next slide. So slightly different story with follow-up nurse visits being scheduled. You can see that they were able to improve it from about 50% to almost 80% and maintain it almost entirely. But this takes a little bit more work because you have to. It takes more time to see the results when you're implementing a process like this, because you have to train, you have to identify the patients, do the outreach, and then schedule the visit. So this is a little bit more task heavy for the team to be able to do this, but they were still able to figure out a way to make it work it into their workflow and really maintain some significant progress. Next slide. So really, what did they learn? They exceeded their goal by 10%. The 2-week follow-up really resulted in the best opportunity for improvement. They had a lot of buy-in. The provider and this team worked really, really hard. They thought this was really important. They had, they really the provider made sure that the team was recognized. And they really understood that the patient service representative was critical to scheduling follow-up. So that, what that slide doesn't show is, how much work they had to do to schedule, to create that follow-up. And then he also did a great job, and the team did a great job of celebrating successes. So he carved out time to celebrate, which really helps get people excited about the work that they're doing. Next slide. Oh, I think that slide's out of order, but that's okay. So similar story. You can see that they had about 60% blood pressure control in 2014. When they started their PDSA cycles, they were able to really improve it to, well over 80%. And once again, this is just an excellent story of sustainability and how this team managed to create this culture of quality, build in these workflows. And to be clear, this is a tiny, tiny clinic. Basically everybody you saw on the QI team is the people who work in that clinic. So not only is this, possible to do, but it's also possible to do and sustain. Next slide. Okay. Any questions, comments? Sorry, I kept losing my voice. My mother-in-law just called me and told me she had COVID, and now I'm paranoid that I have it. So
this is Amber. I think the example used was very inspiring for me because with working in a small clinic, I feel that a lot of our issues that we encounter are related to workflow and changeover and policy changes that happen rapidly. And so just seeing that example was very helpful. And I really appreciate that. Thank you.
Hey, Aleece, could you go back to your slide with the actual PDSA cycles as they pertain to this? I was curious about.
Andy's controlling. So
Okay, thank you, Andy.
keep going.
one more, I think.
I think it's after the example started.
Yeah.
I think that's what he wanted to see was this,
Yeah.
the 5 PDSA cycles.
Yeah, the 5 PDSA cycles that they actually carried out. And it's not okay. Terrific.
Yeah, so I mean, how they started really makes a lot of sense because you have to
Mhm.
educate people first, right? And without education, you're not going to see the impact because people aren't going to have the buy-in, they're not going to have the knowledge. And honestly, the education, quite honestly, gets you an early win. It's I'm not going to say it's simple or easy to do, but it definitely gets you an early win when you're starting your quality improvement project. Mike, did you have a
Yeah.
question?
No, I think
Yeah,
this
I
is
just want to.
sorry, go ahead, Mike. Yeah.
Yeah, I just want to mention we did something similar in our student health clinic, um, and I think where we started was just normalizing how easy it is to measure the blood pressure incorrectly, and how common it is. And there's a story I like to share. There's a medical student AMA conference in which there was a challenge to see who could get all the steps right, and I think it was like 1 out of 100 something medical students. And I said, if you have this highly compulsive group of people that they don't get this right, it's because there's a lot of moving parts. And also we brought up the incentive for the medical assistants to kind of get it right the first time, because we were going to have a goal of repeating blood pressures, and we didn't want to repeat blood pressures just because we measured the first one incorrectly. And what was helpful for us also was to place an infographic that showed the impact of incorrect measurement steps. And and stories were also helpful. So we had a collegiate runner with a blood pressure very highly hypertensive, and that was because the blood pressure was taken over a sweater, which added 50 millimeters of mercury to his systolic blood pressure.
Yeah, that's a great story. Anybody else? Comments, questions? Right, I think I'm turning it over to Gotham.
Thank you, Aleece. That was terrific. So I want to talk a little bit about out-of-office blood pressure measurements, and this has been an interest of mine, I guess, for more than 20 years. As Dr. Constant knows, I was in the Department of Pediatrics at the University of Pittsburgh for a long, long time. My area of research was hypertension. It still is. And I can tell you that Mike's experience with adults is bad enough, but with kids, our MAs just wanted some number that they could write down. It's very hard to get little ones to sit still for blood pressure. And some of these values are not necessarily meaningful. So home blood pressure monitoring is taking on a bigger and bigger role across age groups. The question is, how do you actually carry it out? And so let's define a few basic terms, and then we'll talk about when to actually do it. I have said this in a previous cardio session. Everyone with hypertension, I believe, should be checking their blood pressure at home. Now, how often they do it is up to them. It can be once in the morning, once in the evening, or it could be once a week, whatever it is. That's certainly something that will help bring about self-awareness of the illness and give you some idea of control. And it's always wonderful when a patient comes in with their scribbled values written down, saying, hey, my pressure is not bad at home. So let's say we have somebody that comes in on a couple of occasions and has an office blood pressure of 130 over 80, but still below 160 over 100. And you've tried some lifestyle modification, but you suspect white coat hypertension, and there's no reason to think, Mike was talking about the runner, for example, probably white coat hypertension or something's wrong with technique. In that case, you have two options. One is a 24-hour ambulatory blood pressure monitor. In my office at any given time, there are approximately 30 or 40 of these devices being stored by the research team. I have tried them all myself personally. They are not fun. They will wake you up in the middle of the night. Some of them are really noisy, especially the cheaper ones. And it's just not something you get reliable values from. So even though 24-hour ABPM is the gold standard, even though it is now covered by Medicare, for example. It is probably not what you want to do if you suspect high white coat hypertension. Home blood pressure monitoring is a more practical method. You measure blood pressure morning and late afternoon 3 times a day. The machines will automatically calculate an average as well. And of course, if it remains high, then you can probably consider treatment. If it looks like it's lower than what you got in the office, you can continue lifestyle changes, some education. So that's how you would use it. Now, the phenomenon of masked hypertension gets a lot less attention. This is someone who comes in and says, I think I have high blood pressure, but you measure it in the office and it's not high. And so it's the opposite of white coat hypertension. And when they're at the Giant Eagle or wherever they happen to be, it happens to be high, or they're using their mom's cuff and it happens to be high. And that is called masked hypertension. It is a cardiovascular risk, in other words, hypertension in certain circumstances, though it's not nearly as significant a risk as white coat hypertension or obviously frank hypertension. You do the same sort of thing. In other words, if their blood pressure is high out of the office, you may consider drug therapy. And of course, if it's not, you'd consider lifestyle changes and continued monitoring. So it's as simple as that. What is the lesson here? The lesson here is I think everyone should have access to a automated blood pressure cuff. They are covered by Medicaid through durable medical equipment providers. And I don't know what people's experience has been. I've sent prescriptions to Discount Drug Mart and CVS, and people have been able to obtain for those of you who don't, Discount Drug Marts here in Northeast Ohio, but CVS, Walgreens, etc. They have been able to obtain devices through Medicaid. So you don't have to go through a DME provider for it. Even if it's not covered, and some of our patients don't have coverage, they are relatively inexpensive. They're a good investment for our patients at about $40 to $50 for an Omron device, which is validated as well. So I encourage you to promote that at every opportunity. So first lesson: if you suspect it's white coat, prescribe, have them do a 3-day protocol, send the results through my chart, send the results on paper, however you communicate with your patients. And if it looks normal, continue to monitor. If it's not, have them come back again, check it again, and consider treatment is what I would suggest. So any questions about that?
This is Arpita. Is this ambulatory blood pressure monitoring like they give a result of the values or like all the readings in last 24 hours?
So great question, Arpita. I didn't want to get too much into the protocol, but it's the blood pressure is taken by the device automatically every 20 minutes during the daytime, every 30 minutes overnight. The values are stored on the device. In our system, university hospitals, and it may be different elsewhere, they have to pick this device up in cardiology, sign it out, bring it back. And our friend Dr. Neeland actually reads a lot of them. He's done a few sessions for us in Echo. What you're looking for is the mean systolic, mean diastolic blood pressure. More importantly, what we call load, the percentage of systolic values or percentage of diastolic values which are above the 95th percentile. So if they have a high systolic or diastolic load, they have hypertension. So it is taking blood pressure periodically over a 24-hour period. It's cumbersome. I have prescribed it and said, go to cardiology, pick up the device. And often, you call there's nothing in the chart, 2 weeks later, because they never went. So it's extremely challenging. The devices cost around $2,000. The number we have lost is quite significant just on a research standpoint. I anticipate that's or damaged as well. So it's cumbersome and difficult for a number of reasons, even though that is the gold standard as well for diagnosis.
Thank you.
Any other questions? Okay. The case discussion today, and I know we have to leave time, which I'm hoping Andy will keep me.
And Dr. Rao.
Yes. Go ahead.
This is Jim from East Liverpool. Since we're talking about ambulatory blood pressure that's working 24 hours a day. So please correct me if I'm wrong. There's also, I think, an important parameter that we should observe in terms of nighttime
Yeah.
dips in blood pressure, which is important because I think if there is no nighttime dips in blood pressure, ambulatory blood pressure monitoring, I think that signals a more vigilant, or should I say, an urgent workup for that matter, right?
Yeah, absolutely, Jim. And I didn't want to get too much. I think in one of our echo sessions, we had a whole session on 24-hour ABPM, and we can certainly talk about it. Nocturnal dipping is a normal phenomenon, about 10% drop in systolic and diastolic blood pressure. If it does not take place, unfortunately, it's more highly correlated with left ventricular hypertrophy and cardiovascular events as well. So that is a more serious sort of thing. So on an ABPM report, you will have all the readings. You have to have 70 to 80% that are valid. If they pull the thing off or if it doesn't record it for whatever reason, you want means for the systolic and diastolic pressure. You want loads. You want whether there was nocturnal dipping or not. And then it's really up to you to interpret that. So the other thing I would say is ambulatory blood pressure monitoring standards are not the same as office clinic. They have a different values that you look for, including at night. So keep all of those things in mind as we go forward. And I'm happy to talk about it at some other occasion. But let's get to our
Thank
case.
you.
So this is a case where I'd like you to apply some of the things that Aleece talked about. So the Linton Center is a 6-provider practice in East Cleveland, and it is charged with developing a plan to address smoking cessation amongst its patients. 42% of adults in the practice smoke cigarettes. Is much, much higher than the Ohio average, which I think is around 20%. Only 10% have received any documented counseling. Now, we talked about this before. Documented counseling is not necessary. It says that you have done something, but quite often we do provide counseling either formally or informally, and we don't document it. As I said, if I have a patient who smokes, I almost always mention something. I don't always write it down, but nevertheless, making this a project would raise awareness of the issue. So let's talk briefly about setting up an objective and a hypothesis and some sort of plan. What ideas do people have to address this?
Time crunch, I think workflow of the clinic and also like age group of the patients.
Okay, so Arpita, how would you get started? What would be your objective, for example, if you were to set a goal?
Um, I I would aim for reducing the percentage of smoking adults from 42% to maybe like 38%, like 5% goal in next 6 months by having telehealth appointments and regular follow-ups.
Okay, so you would want to reduce the percentage of smokers over a time-limited period by about 5%. So those who have achieved some degree of cessation, however you define it, and we don't need to get into the details of that. And your strategy would be what for that?
Scheduling telehealth counseling sessions with the patients and like medication therapy.
Okay, so you are identifying smokers, and then you are setting up these appointments. Okay. For telehealth with who's going to do that?
Um, Either with the provider or the clinical pharmacist who can prescribe medications if needed for smoking cessation.
Okay. Okay. And I don't want to pick on you too much, Arpita, but what would be your process measures and things?
Process measures will be how percentage of patients willing, I mean, answered, scheduled the follow-ups
Mm-hmm.
versus that will be one of the process measure, like scheduled follow-up or not. And the second will be, are they willing to quit or not?
Okay. Okay. All right. Interesting thoughts, I think. Very interesting strategy for promoting cessation. I'm just thinking, Arpita, you and I see pretty much the same population. I can see a lot of people not showing up for these telehealth appointments, but that's something we can overcome. Anybody else have any similar strategies, objectives?
Dr. Rao, it's Jim from
Huh?
East Liverpool.
Go ahead, Jim.
So, looking at this case study, it says only 10% have received any documented cessation counseling.
Mm-hmm.
So that one right there must have come from the healthcare providers. So I would approach this by improving the abilities, or improving healthcare providers identifying this, increasing that percentage, so that those people who have been smoking, and then whether the residents or the MAs will be able to identify if they are a smoker or not, and then they
Mm-hmm.
will automatically, during their visit, um, talk to the patient about smoking cessation. That way, that percentage will increase. So
Mm-hmm.
it's coming more from providers in the clinic, be it MAs or doctors or residents, to increase that. So yeah, that's
Okay.
my thing.
So I think both your strategy and Arpita's strategy are different, but different and both legitimate. So Arpita is saying, I want to increase the number of people who quit, and I'm going to give them the opportunity to receive counseling. And that's going to attract, perhaps of those 42%, it's going to attract a small percentage who are motivated to quit and are seeking help and trust their provider, and are going to show up for the telehealth appointment. That might reach that objective that she has, which is modest but reasonable, of 5%. Yours is more of an opportunistic sort of process measure. And what you're saying essentially is, okay, these providers are not providing counseling very often, or at least they're not documenting it. Maybe they're not identifying who smokes. Maybe they don't have time. Let's put in a plan and let's motivate them. And of course, only a small percentage of people who receive the counseling are going to quit, but perhaps that might also be about 5%. What happens if neither of these work? Let's give that last question to both of you, and then we can turn it over to our updates. What would you do?
If the patients are not scheduling telehealth, I would recommend, like, as Jim mentioned, like, checking the percentage of populations with different providers to see throughout the clinic who has like highest percentage, and see, like, process workflow to see why there is a lag, or like if it's
Mm-hmm.
consistently between the providers, then having a plan through the ambulatory manager or population health on outreach, and also like working with the pharmacists to see like if they can have more patients, seeing these kind of patients to help with the not just the counseling, because most of them, they don't like counseling, they want medication treatments, so to see if that will help.
Okay, very good. All right, thank you, Arpita. Thank you, Jim, for your insights. I'm going to turn things over. I think,
Thank you.
Andy, we're ready for our updates. And I think we can start with Erie County. Chesney? Okay.
I see Heather on the line also. Heather, are you there to give an update?
Yep, I'm on here. I'm sorry, my mic just wasn't working.
Oh, hi.
I wasn't sure if
Chesney.
Heather wanted to talk a little bit too.
Why don't you start, Chesney? We can go to
Okay.
Heather.
So as far as updates, our cardio project is going really well thus far. I feel like we've been able to kind of keep track of specific, data, which has been helpful in terms of, I feel like when you're not, like for me, like being more administrative, when you're not directly in patient care, it's interesting to see, when the patient's A1C is above 9 and things like that, and just being able to track that progress over time. In addition, we have begun implementing our food kits, which is part of what we talked with Amanda about as part of our plan. So the food kits being implemented, I think, will be a very great addition to this as well. But overall, I feel like it's going well. Heather, Nikki, and I have worked on it pretty in depth and have ensured that all of our processes are good and all of our staff is aware, which I think has been helpful as well because everyone's on the same page also.
And Chesney, can you tell us a little bit about the food kits?
Yeah, so we partnered with an organization called OGO, and then it's through Second Harvest. So we were provided produce that if we have a patient, that's diabetic or even hypertensive or has food insecurity, we're able to supply them with a food kit. And Heather's idea was, which was a very good idea, was that if we have a diabetic patient and it's demonstrated that, that they have issues with food or they don't know how to make specific meals or eat something that would be more supportive of their diabetes, that we could gather them a food kit and just give them additional instructions to kind of help modify their diet. So that's one of our main target points for this, is to see how that can help improve those measures.
Okay, thank you. Heather, did you have any additional comments? Heather's on.
Can you hear me okay? I know
Yeah,
I
we
have
can
a
hear you.
full working mic. No, I think Chesney summed it up well, and just really trying to connect patients to those food resource kits and then educating them on how to make healthier lifestyle choices with those food resource kits instead of going to the local gas station and buying whatever at hand. Here's a food resource kit, and let's teach you how to cook of these some of these recipes at home. And then we're hoping to add a fresh produce resource kit in addition to this food, shelf-stable food that we currently have. So we're hoping it's in pending progress, but I don't know, with the political environment, Second Harvest has taken a hit in their funding. So it's unsettling to us to see that we may not have access for our patients for that fresh produce.
Okay, thank you, Heather. Andy has told me we can go down to the healthcare connection. Nate, are you on? Nate Luce? I think I see him dialed in. Okay, maybe we can come back to Nate. Arpitha, do you want to give us an update on your project?
Yes. So our QI is to reduce the percentage of patients who are not on statins with ASCVD risk from 48% to, by 10% in a year. So we have a workflow which we changed yesterday tiny bit. So we are identifying a list of patients under the 3 providers who has ASCVD risk over 10%, and we are giving the list of the patients to nurse manager who assigns an MTA to call and schedule follow-ups with the provider. And if they do not have a cholesterol lab done in last 6 months, the MTA prints the order and route to the provider for sign. And then it's actually going very well. We could reduce the, we were able to identify the patients who are interested, and there is at least according to the data, I see like 5% improvement in one of the providers, but not like consistently. So we are working on the flow But we are trying to identify patients who agreed to the statin, refused, and intolerant, and who are on other cholesterol medications. So that is added into the workflow, and we'll be working every 3 months on the follow-ups for patients who refused the statins.
So the goal, Arpita, is to have statins considered for those patients who have an ASCVD 10-year risk of 10% or higher, correct?
Yes.
Okay. All right. Yeah, we've in our group sessions, we review this project. I think it's an outstanding project overall. And a couple of things. Obviously, I'm on the AHA committee that has designed the new PREVENT calculator, which will be replacing the ASCVD calculator, but that's a separate issue. We can think about that in the future. It's not going to be that different in terms of its calculation, but
It's called Prevent Calculator, right?
yeah.
Last meeting you mentioned about it. Thank you.
Yeah, I don't know if your data team at Metro or within Epic, it's been incorporated to the degree that you can use that across your patients to identify their risk, but it is more accurate. It's based upon millions of patients, a much more diverse population than the pooled cohort equations. It gives you a 10 and a 30-year risk. It takes social determinants of health into account, many, many different advantages, but something to think about as your project rolls out in the future. But overall, great work.
Thank you.
Amber from Village of Healing.
Good morning.
Morning.
Our project is focused on improving controlled blood pressure rates in our patients with diagnosed hypertension. We're trying to improve that rate, up to 30% or 15%, increase in 15% by our deadline. And we've started with the education of the team, which went very well. Then we focused on the technique of taking our blood pressures very well in office. If they're high, our machines have like a cycle where it'll take the blood pressure 3 times and then produce the average. So that allows for the patient to sit and, cycle through. We've even started to implement when we get the patient, we sit the patient down in the room and then come back in and get their blood pressure after the intake and the questions happens to give them that extra few minutes to rest. Especially in our second location, because a lot of our feedback from our patients is that they have to walk far into our building from the parking lot because it gets pretty packed in the parking lot. So they have to walk pretty far, so they get out of breath, etc. So we've been implementing having those patients sit and relax. We've been seeing our numbers improve, our patients' blood pressures improve. They're coming for their follow-up appointments with the nurse. They're doing 3 nurse visits in 2-week intervals. And we just trialed that. That's our first one. So we only have 2 patients doing that in this moment. And we've got mixed reviews. So far, things are going very well.
Good. I really like your project, Amber, and you followed the example that Aleece gave for the Metro Health practice almost to the letter. So I think I'm very optimistic about its impact. Great. And I think we have East Liverpool as well. Somebody on from there.
Yes, Dr. Rao, it's Jim.
Oh, hi, Jim. Go ahead.
Yes. So with our QI project, so it's hitting a target goal of LDL less than 70 for patients with ASCVD risk factors using an adjusting statin, ezetimibe, bempedoic acid, and PCSK9. So at this point in time, we have identified those patients and followed a trend. And so far, our monitoring, we were able to track down, we were able to make adjustments of medications for those patients. And there are patients that we found out that they're not really compliant with their medication, because when they say, yes, I've been taking it, and then when I looked at the medication logs for refills, the refill was like there's a gap in their requests. So that's where I was able to find out whether they're, compliant with the medication or not. So yeah, we've identified those, and we will address those during their clinical visits.
Okay, so this project entails selecting patients with a very high ASCVD 10-year risk and
Mm-hmm.
trying to get them to a goal LDL of 10% of a 70 or lower
Yeah.
through either please take your statin, 20 milligrams of torvastatin
Yeah.
a night, or
Yeah.
higher dose statin if they're able to tolerate, or in
Yeah.
some cases, if it really comes to it, a PCSK9 inhibitor
Yeah.
as well. Okay,
Yeah.
right.
Yeah.
And do you have any examples of patients that have been successful?
Yes, yes. We have patients that have already reached their target goal of less than 70.
Mhm.
So we already set them aside while focusing on patients that are not compliant. And the way I tracked it down is looking at those prescription logs. So, yep. So we've had
I see.
successful
Okay.
patients already.
So since your project started, you've had some people who've reached an LDL of 70 or lower.
Yes, we
Okay. Oh,
have.
wow. Okay. Through
Yeah.
intensification of treatment. And now you're
Yes.
focused on a different population that is obviously has a problem with adherence or engagement with
Yeah.
their medication. Interesting.
Yes.
Very interesting.
Yep.
Okay.
Yep.
Wow. Okay. Terrific work.
Thank you.
And you've got Austin and Dr. Swain involved, which is wonderful. Okay, I'm going to go back for a moment to Nate. Nate, are you available?
Can everybody hear me?
Yeah, we can hear you, Nate. Can you give us an update?
Yes. Yeah. Sorry about the technical difficulties earlier, but we are pushing forward with controlling hypertension. So, folks that are diagnosed and have had an in-office blood pressure above 140 over 90 is our target population, and we are trying to get them scheduled with me, the clinical pharmacist, for follow-up, kind of in between visits. It's been going okay. The visits are getting scheduled, and if they show up, we can definitely do a lot of things. But one thing that's made I think a big impact is what Mike had mentioned earlier, was the accurate measuring of blood pressure. So it's actually in a coaching session that Mike had mentioned, I think it was the AMA diagram of how to accurately measure a blood pressure.
Yeah. We've
put those up in most of our patient rooms at this point, and we're seeing a big change in the overall blood pressure reading. So that's helping, I think, lower the number, just because we're getting an accurate reading now. But then working with nursing staff is kind of where we're at this point, to kind of help coordinate with the visits, getting those scheduled, follow-ups, and all of that. Getting policies in place as well, so that we can hopefully get the number of folks down.
Terrific, Nate. Couple of questions for you. How's the show rate for the appointments with you?
It's creeping up. I think with the heat wave, that was a big drawback. I think our no-show rate skyrocketed probably by about 20 or 30% across all sites. But it's starting to improve a little bit now. Okay,
good. That's one thing. I know that measurement is a huge barrier. I'm assuming you're using oscillometric automated blood pressure cuffs, which is what's recommended.
Correct.
All the time. And some of the lessons I've learned over the last many years is that to have a wide variety of cuff sizes available to the MAs at all times. And of course, to have, the bare arm, have the patient seated, so that the NIH AMA diagram is important to have. So I think you're doing all the right things. It is hard to get folks to show up for an adjustment appointment with the pharmacist, and when they say, "Oh, your blood pressure's still high," but hopefully, as you roll it out, you'll start to refine your methods for engaging them as well. So great job so far. Okay. I think that's all we have the updates we have. So let me turn things back to Andy for a moment.
Just a few reminders. I sent out a post-clinic survey that should be in your inbox. If you can complete that by tomorrow, that'd be wonderful. Otherwise, your July data is due today, so please submit that or let us know if you're having issues with it. And our next clinic will be September 4th over process mapping.
Okay. Thank you, everyone. Have a wonderful rest of the week, and we'll see you soon. Bye-bye.
Thank you.
Thank you.